Hello people, today I am studying respiratory system and I'm really enjoying the process, but I want to vlog out things and make it more interesting. So what I have decided is there are many topics, so one by one I am going to complete it and going to speak about it for a minute. So till now I have learned about Wibble's criteria. There is 0 to 23 generations. From at 16 generation it is known as conducting zone, where there is terminal bronchioles, and after 16 to 23 it is called as another zone which I forgot. So it is your transitional zone, in which there are alveolar ducts and alveoli. Then I learned a little about mechanics of breathing, that at inspiration stage they are in negative. The main thing is why they are in negative, because the pleural space is basically empty. There is vacuum in that, but because of that vacuum only, uh, there are two opposing forces. Tendency of the lung is to collapse as well as expand. Now there is one thing called as intrapleural lymphatics. What they will do is they will drain the fluid from the pleura. That is why at in the stage of inspiration your pressures are negative, means at rest it is -2 to -3, but when it is at inspiration is -7 to -8. Then when expiration occurs it again comes to +1. So yeah, this trend is what our lungs follow. And another thing is your TPP, that is your transpulmonary pressure. What is transpulmonary pressure? It is basically IPP minus IAP, which is always positive, and which is, if your inspiratory pressure is -2 to -3, your your TPP will be +2 to +3. You know why? Because there's a formula that is TPP is equal to IPP minus IAP. So IPP is 0. That's why it is +2 to +3 at rest, and +7 to +8 at the time of inspiration. And there are a lot more things which I have learned, but I am telling you the very basics which I have captured. That's all. Meet you soon again. The next topic I learned, that was all about compliance, and I learned about hysteresis loop. And this was one of the topic which was confusing to me when there was class of ventilation by Manish sir. That's why I was smiling when I was studying that topic, because it is more and more clear right now. This is a graph between delta V by delta P, which gives us compliance, and when it shifts to the right side there is some restrictive disease such as atelectasis, ARDS or pulmonary edema, and when it shifts to your left side there is some obstructive lung disease such as COPD. Why so? Because in COPD there is your x-axis pe there is pressure. In COPD there is airway trapping, that means volume is increased and pressure is decreased. So pressure is inversely proportional to compliance, so it shifts to your left side. But in your restrictive lung disease, your pressure is increased and compliance is decreased, so it shifts to your right side. Yeah. That's all. And further I learned about FRC, which is the volume in the air, the volume of the air in the lung at the end of the normal expiration. And then I learned something about static compliance and your dynamic compliance. So dynamic compliance is in the cases such as ARDS, pulmonary edema, atelectasis, and static compliance is with resistance, and it is in the cases of kinking of ET tube. And that's all. Let's dive into another topic right now. So yeah, the next topic which I read was COPD, and I learned some very new points about that, but telling from very basic to a little complex. So let's start. COPD patient comes with a classical history of cough, sputum and dyspnea. Further, there is three more things. One is your mucus glands hyperplasia, leading to more mucus secretion. Second is neutrophils will be coming out in the sputum, and the third thing is your squamous metaplasia in COPD. Now, what is the guidelines which is followed in COPD? They are the gold guidelines, and in this we see the FEV1 by FEV1. Wait, I forgot. FEV1 by FVC ratio, if it is grade 1, 2, 3, 4, more than 80% is 1, 50 to 80 is 2, 30 to 50 is 3, and less than 30 is your fourth. So further, what is the what comes in COPD? There are two diseases which comes in COPD. One is your chronic bronchitis and another is your emphysema. And what is the difference between two? The main difference between two is your chronic bronchitis is something which is clinical and your emphysema is something which is pathological. In your chronic bronchitis, there is history of cough with sputum. On the other hand, in emphysema, you will see the hyperresonant on percussion, you will see Hoover sign, and there will be some bubbling sounds present in the neck, in the chest. Further, in your emphysema, there will be pink puffers, but in chronic bronchitis there will be blue blotters. In your emphysema, there will be history of right heart failure, PAH, means COPD is leading to pulmonary artery hypertension, leading to your core pulmonary or right ventricular hypertrophy. But in your chronic bronchitis, there will be no history like that. And what is difference between asthma and COPD? Asthma is reversible disease, COPD is irreversible disease. Asthma is a disease in which there will be raised acute eosinophil count, rather than in COPD there will be not raised eosinophil count. In asthma there will be smooth airways, but in COPD there will be obstructed airways. This is the main difference basically. Further, what is the management in COPD? We give two main drugs. One is actually three main drugs, triple response, but initially two main drugs. That is your LAMA and LABA and ICS. LABA is your long-acting beta agonist, and ICS is your inhaled corticosteroids, and we give these two drugs, that is formaldehyde and your steroids, hydrocortisone. But if there is no prevention in exacerbation, we add a more drug, that is your LAMA, that is long-acting muscarinic antagonist. Why? Because might be triple response reduces some exacerbation, and that third drug is known as tiotropium bromide. So yeah, this was the third topic which I studied and enjoyed. I really want to complete respiratory failure, ARDS and everything further, but there is so much in that theory that I cannot just read it and leave it. Something, if I am learning, I want to just learn it very nicely. That's other thing that I have seen the cases of ARDS, your pulmonary edema and atelectasis. Further, asthma, one ACOS case was also nice, pneumothorax. But I will see the theory later on. Right now I I'm heading towards hostel and I'll go to sleep. Today I was able to cover 3 topics, but to my heart I can say that these 3 topics are on my tips. And if question comes from anywhere, I can solve that. So this is a little relief or contentment I can give to myself right now. So that's all. Dr. Bansal is signing off right now. Bye bye.